Hi, everyone. My name is Stephanie Suarez Gonzalez. I am the Clinic Partnership Manager for MAVEN Project. Thank you all for joining us today, and thanks to our friends at El Rio FNP Residency in Arizona for requesting today's session, Chest Pain Evaluation in Children and Adolescents. Gerald Angoff, MD, MBA, was most recently an assistant clinical professor of pediatrics at Dartmouth Hitchcock Medical Center in New Hampshire. He specializes in pediatric and adult congenital heart disease and served as a co-director of the Dartmouth Hitchcock Adult Congenital Heart Program. Dr. Angoff is a certified physician executive, a Six Sigma Green Belt, and has an MBA with a concentration in medical management from the University of Massachusetts. He volunteers in the West Indies County of Grenada, seeing children and adults with congenital and rheumatic heart disease. And with that, I'll pass it off to Dr. Angoff to begin our session.
I'm sharing my screen. Is it visible?
Yes, it is.
Good morning. Chest pain evaluation in children and adolescents. I have no conflicts, and as mentioned, this talk is qualifies for one credit category 1. As for objectives of the talk, to explain how chest pain in children differs from adults, to be able to use a careful history and examination to define chest pain risk characteristics, and to complete a chest pain evaluation confidently with minimal need for testing and evaluation. Okay, of those objectives. As an overview or an outline, a little bit about my background. I like to go through 3 clinical scenarios and see what you think, and to discuss what I call the pediatric chest pain conundrum, to discuss some data from the literature, to go through some thoughts about diagnosis and treatment, and finish with some conclusions. I'm a clinical cardiologist, as mentioned, most recently at Dartmouth Hitchcock in New Hampshire, and my career has involved both adult and pediatric cardiology, with most recent focus on adult congenital heart disease. I've also been a consultant in medical information technology, concentrating on process optimized workflows, quality and outcomes, and this process bent that I have, I think you'll kind of see through the talk today, hopefully. I'd like to start with some pre-evaluation questions for you, and we have this set up as a poll. To start with, there are 4 questions. Do you perform pediatric chest pain evaluations? Do you feel comfortable performing these evaluations? Do you know what key history and exam elements should be? And do you know what role testing should have? So these thoughts, these questions will link to elements in the talk. If you can answer those, and I'll get a little bit of a better idea as to where you folks are coming from. Allow me, I think, to address where you are more effectively. How's that going, Stephanie? Is folks answering?
Yes, that's gonna give 5 more seconds. All right, I'm gonna go ahead and end that poll for you. Share the results.
They are one source of a computer, so we're only getting 2 responses. Just well, anyway, think of these questions. As we go through the rest of the talk. Clinical scenarios. There are 3. I'd like to get some of your reactions. The first is a 15-year-old young lady high school with chest pain of 2 weeks duration, referred for pediatric cardiology consultation. She was in the emergency room the day after the onset of her symptom, EKG, chest X-ray, lab testing, chest CT were all normal. She was there for several hours, you might imagine. The cost in terms of what was billed was $7,000 or more. I'm sure as days goes on, it gets to be more and more. The chest pain story, the history at the time of her consultation was helpful, and this will be a theme that will I'll continue to develop through this talk. That history is primary. Sharp stabbing symptom initially, 7 out of 10 severity, lasting seconds. Left upper chest radiating to the shoulder and back. It was pleuritic and positional, occurring multiple times per day and improving with NSAIDs. So here's my question for you. If you can't answer directly, think about what you would say. Is this likely, possibly, or unlikely to be a cardiac symptom, to be due to a cardiac condition? Kind of make a little note for yourself if you can't respond directly. Okay. All right. So let's kind of delve further. Again, history. And the day before onset was the first cheerleader practice of the season. She was a cheerleader, and she helped toss her teammate into the air. And she awoke the next day with the pain. And at the time of her visit, the pain was almost gone, diminishing progressively. Her physical examination was notable for a pain that was present with deep inspiration over the and the left upper chest was tender on firm palpation, reproducing her symptom. Treatment was reassurance. The story was most consistent with musculoskeletal symptoms, the musculoskeletal source. Okay, second clinical scenario. A 7-year-old boy with chest pain and shortness of breath of 2 months duration, again referred for pediatric cardiology consultation. He'd had multiple primary care visits. An EKG and chest X-ray were normal. He was given a trial of an inhaler, which did not help. Again, further history. The symptom, the chest discomfort, was in the morning most days. There was a pressure sensation lasting hours. It was diffuse. It was worse with breathing. It was exclusively at rest. He had associated shortness of breath and some improvement actually with activity and exertion. Again, unlikely, possibly, or likely due to a heart condition. Kind of jot down for yourself a note. Think. One unlikely, one possibly. Okay, so further history. Missed many days from his new school. He had recently changed schools because the family needed to move. And they needed to move because the family house had burned down. And the family house had burned down 2 months, the duration of the symptoms, previously on Christmas Eve. He said when he was asked that he lost all of his toys and presents in the fire, and he started to cry. His physical examination was normal. And for treatment, reassurance, and in this case, particularly recommendation for counseling. Again, not a cardiac symptom. Third clinical scenario. A 12-year-old boy referred for a medical excuse from school gym class. His history, 2 to 3 months of vague exertional central chest aching, occurring most recently playing basketball, rapidly relieved with rest. He had no resting symptoms. He was otherwise well, without family history of any premature or familial cardiac disease, hyperlipidemia, sudden death. His examination was normal oxygen saturation, no murmurs, pulse is all normal, and his EKG was normal. Once again, kind of jot down for yourself, unlikely, possibly, or likely a cardiac symptom. Okay, one possibly, one likely. Further data, an echocardiogram showed normal cardiac size and function, normal valves, normal pulmonary pressure. There was an anomalous coronary artery origin, with the left main coronary artery starting from the right coronary artery and coursing between the main pulmonary artery and the aorta. So the left main coronary artery was between the main pulmonary artery and the aorta, in a position where it could get pinched, particularly with systolic expansion of those blood vessels. He was referred for cardiac MRI and possible intervention. In such cases, sometimes surgery is needed. So in this case, indeed, the symptom was cardiac in origin. History was particularly helpful here, as before, in directing towards that possibility. Okay, what about the chest pain conundrums, which I alluded at the beginning? Here are some key thoughts and points. Chest pain is frequent in childhood, and the symptom creates a high level of concern, particularly among both the family and the providers, resulting often in urgent referrals, emergency room visits, urgent care visits. The cost for evaluation is high. And here's the overriding point. A cardiac cause of chest pain in children is rare. It's rare. Of note, children are not small adults. Heart attacks, myocardial infarction, with extremely rare exceptions, do not occur in children. So what might be causes of chest pain? Well, if you look at literature and some textbooks, you'll see something like this for cardiac causes. I know you can't read this. And pulmonary causes, again, a number. And here's the point. Such lists are not helpful. There's no way you're going to exclude or even consider all of these reasons or causes. So what about history? As I've mentioned now multiple times, history is primary. It's often sparse, which means you have to ask questions and delve further. What are key elements? Well, certainly onset, timing and circumstance, duration, frequency, character, what's it like, intensity, location, radiation, where else is it felt? What does it move towards or to? What factors might make it worse? What factors may provide relief? Is there an exertional relationship? Are there other related symptoms such as dizziness or shortness of breath? And as an example, acute onset of severe, sharp, stabbing, pleuritic pain in the center of the chest without relationship to exertion, lasting seconds, occurring off and on over 2 days, relieved with ibuprofen and improved with exercise. This is one phrase encompassing most of these elements. The product of a careful history. And if you read this phrase, you would, I think, have a relatively easy time making a decision about the likelihood or not that the symptom was cardiac. Okay, well, what about the literature? A couple of articles that actually help out. The first from Pediatrics in 2011 evaluated or looked at retrospectively 3,700 children who had been seen for chest pain retrospectively. A cardiac cause of any sort was determined in just 37 cases, or 1%. In the series, there were 3 deaths, but they weren't cardiac, 2 suicides, 1 spontaneous retroperitoneal hemorrhage. And no patient discharged from the clinic after the evaluation died as a result of a cardiac condition. Well, okay, if it's not cardiac, what's it likely to be? In this series, the most common cause was unknown. Most of the symptoms were not specifically diagnosed and resolved. Of those that were diagnosed or considered, the common causes were musculoskeletal, pulmonary, gastrointestinal, and anxiety. The box lists the cardiac conditions, that 1%. But actually, only 19 of those 3,700 patients actually had intrinsic cardiac disease, or just 0.5%. Delving down on those cardiac causes, pericarditis, myocarditis, an anomalous coronary artery, as one of our scenario cases had, hypertrophic cardiomyopathy and dilated cardiomyopathy were the cardiac intrinsic causes. Another study from Pediatrics, 2013, looked at a guideline for evaluation of chest pain in children. Here, a little over 1,000 patients, age 7 to 21 years, and just 2 out of the 1,000 or so had chest discomfort due to a cardiac etiology, 0.2%, 1 with pericarditis and 1 again with an anomalous coronary artery. Testing that was performed outside the guideline only demonstrated incidental findings, and patients returning for persistent symptoms and who underwent reevaluation did not have cardiac disease. Key abnormal elements to look for in the guideline. Again, history. Chest pain with exertion, any syncope associated with the symptom, radiation, back jaw, left arm, shoulder, anginal type qualities, supine or with fever suggesting pericarditis. Again, history, this time family history, sudden death, cardiomyopathy, hypercoagulable state. Abnormalities of physical examination that actually demonstrated or were consistent with some acute illness, fever, and signs of pericarditis, a non-innocent murmur. Innocent murmurs are common in children, but a murmur that really sounded pathological, and any abnormality to EKG. If any of these elements suggested a cardiac cause, then the next step was an echocardiogram. Again, there are the historical factors in the examination findings. And in terms of EKG abnormality, they weren't trivial EKG findings, not non-specific or suggestions of this, that, or borderline, but findings of right ventricular hypertrophy, LVH, more than a little ST segment changes. An S1Q3T3 pattern is what you can see in pulmonary embolization, or a long QT interval. These were findings that were considered in the study true abnormalities of concern. With the echocardiogram studies, the two cases were identified, the pericarditis and the abnormal coronary artery. But there are a lot of incidental findings that were often misleading and confusing. So it was a mixed blessing. Additional testing was unhelpful. And this was another comment at the beginning when I mentioned consider the value of testing. Here, exercise testing and ambulatory monitoring provided no beneficial data at all. It was considered to be unhelpful and not warranted. A further extension of that study, now over 3,000 patients, showed pretty much the same findings, in that the abnormalities here just 0.25% in the study: myocarditis, pericarditis, hypertrophic cardiomyopathy, and one anomalous coronary artery. Pretty much the same conditions. What about the non-cardiac causes in the series? Again, musculoskeletal, gastrointestinal, pulmonary, specifically history of asthma was common, and psychological issues, anxiety, other factors of under that banner. Okay, well, what about treatments? Well, based on what I've developed, the idea that with a very careful history and in addition physical examination, that one can pretty confidently conclude whether a symptom might be cardiac in origin, that treatment first on the list might be just nothing. Or certainly observation over time to see whether or not indeed the symptom gets better, goes away, or whether or not a cause with additional history becomes apparent. Reassurance is a big part of it, to be able to discuss with patient and family that chest discomfort, as I've developed, is rarely due to a cardiac cause. And not only are the causes that are identified likely to resolve, but they don't represent a risk or a danger. For musculoskeletal symptoms, certainly non-steroidal anti-inflammatory drugs. If it's an exertional symptom, perhaps a trial of an inhaler. If the history suggests more of a GI origin, certainly a trial of antacids. To address any anxiety and depression, maybe delve into some history here. What's going on at school? What's going on at home? Like our 7-year-old whose house burnt down on Christmas Eve. That direction of questioning certainly provided the key direction to next steps. Relaxing techniques are often helpful and don't have to be sophisticated instructions on meditation, but you can often talk with some of your patients, particularly if they're older and if anxiety is the focus, the conclusion, and in some cases counseling, as I had mentioned. Okay, so what about conclusions? Well, first, to emphasize again, a cardiac cause of chest pain in children is rare, and as I've developed, can be excluded by an outpatient examination. To be hesitant about referring to emergency rooms where cost and time are often both wasted. A careful history is essential. Key elements on history exam help, that list that I went through. An EKG is worthwhile for initial screening, again, to look for some of those substantial abnormalities that were in my list, and to determine whether or not next steps might be necessary. And in terms of next steps, testing, an echo is best when disease is expected, when any abnormalities of history examination or EKG really point to the possibility of cardiac disease. And that the other cardiac tests, as I mentioned, just aren't beneficial. Treatments are usually symptomatic and include reassurance. Okay, perhaps to review the questions that I offered at the beginning, and maybe again make some notes to yourself. Do you feel comfortable now performing chest pain evaluations? What key history and exam elements should be, and the role of testing? And yes, hopefully, yes to all. I'd like to read this paragraph. It comes from some writing of Bernard Lown, an extraordinary individual cardiologist, and whom I had a chance to train. Of all the skills mastered by a physician, listening is by far the most difficult. One learns to be attentive to the fluttering eyelid, the inaudible sigh, the unshed tear. Proper listening enables one to comprehend the unique narrative of another human being. Even at its scientific best, medicine is dependent on the intimate story. For doctors, this is an exhilarating act of discovery. For patients, it defines a healer. Medicine is ultimately a social discipline. It begins with a unique story from a fellow human being craving help. I think these thoughts relate to the evaluation of chest discomfort in children that I've gone through. The importance of history, finding out about your patient, being a good listener, and I think being able then to provide care directly with hopefully assurance. Be happy to take questions about the topics, the scenarios that I outlined, or anything related or that comes to mind.
Feel free to drop any questions in that the chat or in the Q&A section. And while you're preparing your questions, just a few reminders. Obviously, we hope that you enjoyed today's session, and just note that within the next 2 weeks, the recording will be placed on our community portal under the on-demand library with all of our other recorded educational sessions. And also another reminder that MAVEN Project does offer mentoring to all of our community providers at any point in your career. Any topics are open to that. We also offer specialty specific mentoring like EKG or CGM. And so that is available as well. And you can also request mentoring on our portal. There is one question. It says, what are the most common etiology for pericarditis and myocarditis in children? I can speak this morning.
It's a good question. The most common cause of pericarditis and myocarditis in children is a viral infection. The peak is often at the end of the summer. The Coxsackie virus can cause pericarditis, notably. There are other viral infections that can cause myocarditis and pericarditis. It actually can occur with influenza, and we recently had the experience of cardiac conditions related to COVID and COVID vaccination, actually. COVID, particularly in the early phase of the epidemic, with the more severe illnesses before there was mitigation with vaccination and with medication, there could be a direct attack of the virus on the heart, causing pericarditis, myocarditis, and considerable damage to heart function and the toxic effect of the virus. There was also pericarditis that seemed to be an autoimmune variety. Early on, after vaccination, there was an incidence of transient pericarditis that seemed to be caused from the vaccination, particularly. There was a symptom in children that resembled Kawasaki's disease that would occur starting a couple of weeks after infection. It was likely, again, an autoimmune effect where there would be inflammation of the heart and some impacts on the coronary arteries, like Kawasaki's disease. So basically, viral infection is of the known causes that would result in pericarditis. We don't see rheumatic heart disease much anymore. As mentioned, I've gone to the West Indies island country of Grenada, where rheumatic heart disease was exceedingly common, and in the United States in the early and mid 20th century, rheumatic heart disease was quite common, and there it's likely a type of an autoimmune impact, inflammation of the heart after strep infections. And to avoid rheumatic fever is why you give penicillin for strep throat. So strep throat untreated will resolve on its own, but the reason for all of the intensity of providing penicillin to get rid of strep throats is to avoid rheumatic fever. It's now more in the United States a history of that's passed, although there still are sporadic cases of rheumatic fever and rheumatic heart disease. In my pediatric cardiology experience, we'd see about 1 or 2 cases a year in the pediatric cardiology practice, so it's not completely gone and still worth mentioning.
Questions?
I should mention that with COVID, it's likely that COVID will become endemic, and if you do have a child or a young person coming into your practice who's had a recent COVID infection that was severe enough to keep them out of school, away from activity, that and then their symptoms have that time frame of an association, not months or a year afterwards, but certainly if there's a close time frame, that's sort of something to keep in mind. What's helpful in that situation? Well, just as in the guideline, if those elements of history that point towards a cardiac cause, an echocardiogram is extremely helpful in looking at cardiac structure and function, to look for pericardial fluid, and to help either define some inflammatory abnormality. You might see some decrease in ventricular function if it's myocarditis, or to give you the reassurance that the heart's not involved.
I'm not seeing any other questions. I do just want to thank you, Dr. Angoff, for providing this session for us and for our Anchor Clinic for requesting it. Again, if you have any questions, please don't hesitate to reach out to us. We're here to help. Besides that, thank you for participating in today's CME session, and we hope you have a wonderful rest of your day. Thank you, everyone.
Thank you, everybody.
Bye.